Depending on your time zone, good morning, good afternoon, good evening, or good night. Welcome to a follow-up session with questions related to our recent ATS ERS joint webinar on global perspectives on COVID-19. My name is Juan Carlos Celedon. I'm President-elect of the American Thoracic Society, ATS. I'm the Niels Jern Professor of Pediatrics and Medicine at the University of Pittsburgh and Chief of Pulmonary Medicine at UPMC Children's Hospital of Pittsburgh. I'm joined here today by my co-moderator, Dr. Eva Polverino. Dr. Polverino is Secretary of Assembly 10 and Head-elect of Assembly 10 of the European Respiratory Society, ERS. She's also a pulmonologist at the Vall d'Hebron Hospital in Barcelona, Spain. I would like to again thank the ERS for their collaboration on this webinar, as well as our distinguished international panel of speakers for their willingness to answer important questions about the ongoing COVID-19 pandemic. This webinar session will include practitioners and professors from France, Italy, Germany, and the US. We will try to answer questions trying to cover the most relevant aspects of this pandemic, namely pathophysiology, epidemiology, general clinical care, therapy, antivirals, anti-inflammatories, other therapeutic aspects, ventilation, prognosis of the disease, and concerns about the future. With this, I will turn it over to my co-moderator, Dr. Polverino, who will introduce the first distinguished speaker today.
Thank you very much, Juan Carlos. So the first speaker of today is Tobias Welter, past president of the European Respiratory Society and professor of pulmonary medicine and director of the Department of Pulmonary and Infectious Diseases at Hanover University in Germany. So the first question is very clinical and it's related to clinical presentation. So Professor Welter, why so different clinical presentations, going from acute bronchitis, flu symptoms, or even acute lung failure? What's the reason for that? Is there any prognostic relevant aspect to consider regarding clinical presentation?
Corona SARS-2 is a virus which primarily causes upper airway infection, and people with upper airway infection primarily have a number of typical symptoms, which is fever, cough, as the most important ones. However, during the course of the disease, the virus can move to the lower airways and can cause acute respiratory failure. At the moment, it's not quite clear how this virus does this. The current hypothesis is that the virus infiltrates the epithelium, but without huge damage of the epithelium, and then it's spread to the systemic circulation and induces a pathology which is more similar to autoimmunity than to infectious diseases. What we have seen, and some papers are published a week ago, is that the endothelium is affected, and this endothelium damage is responsible for the capillary leakage and the rise of extrapulmonary lung water, and for thrombosis, this pulmonary embolism, which is responsible for severe course of the disease and mortality in a number of patients. So in conclusion, there are different symptoms with regard to the different compartments in which the disease takes place. In most of the patients, it's upper airway disease only, but in some, it's a more systemic disease with very variable symptoms which can cause acute respiratory failure.
Thank you, Tobias. And the second question is also very related to the first one. So somebody's asking, what is the infectious period of COVID-19? Is this specific to this infection?
If you are infected, the first symptoms in mean occur on day 5 after infection. This is a real problem because patients could be for a long time, 4 to 5 days, asymptomatic. And more important, the PCR diagnostics is not positive before you are symptomatic. So you can be infected, but the PCR test is negative. If you show first symptoms, day 5 to day 7 to day 10 of the disease, then it lasts again 5 to 7 days before you are severely ill. So from the start of the infection until the start of respiratory failure, this is normally 10 to 14 days. Severe disease status occurs in mean 14 days after infection.
Very clear, Professor Tobias. So the following question is just related to therapy. As we all know, the most used drugs nowadays are hydroxychloroquine and anti-inflammatory against IL-6. So what's your opinion about these two drugs?
We more and more understand corona SARS-2 and COVID-19 disease better. And what we are seeing now is there are different types of COVID-19 disease, maybe with regard to genetics. The Chinese and the Asian population demonstrates high fever and a huge inflammatory response in patients who are more severely ill. The Caucasian people demonstrate more problems with embolism and thrombosis. As I said before, this could be genetic. If you look to the hyperinflammatory status, anti-inflammatory treatment seems to be adequate. And from the data we got mainly from China, IL-6 plays a major role for this hyperinflammatory status. So anti-IL-6 treatment seems to protect this hyperinflammatory innate immune response and could therefore be beneficial. Randomized controlled trials with anti-IL-6 are running. They have recruited a high number of patients, and I expect the first clinical results in between the next weeks. With hydroxychloroquine, it's not my favorite. Hydroxychloroquine is a drug which had been used in malaria. Some antiviral activity had been shown in cell culture systems, but looking to what has been shown now in randomized controlled trials, it's very questionable whether it's beneficial in COVID-19 disease. What is quite clear from the data we now have seen is that if you overdose hydroxychloroquine, very high dosages, it's harmful and mainly in terms of cardiotoxicity, and overdosing should be avoided. My conclusion for this is all drugs used in COVID-19 should be only used in randomized controlled trials, and a very careful data safety monitoring board view is needed to avoid harmful effects which are possible for a huge number of drugs which are tested at the moment.
Excellent, Tobias. Thanks for the wide overview. Juan Carlos, please.
Okay. It is now my pleasure to introduce our next speaker today, Dr. Marco Ver. Dr. Umberti is the Vice President of the ERS. He's also a Professor of Respiratory Medicine at the Université Paris-Saclay in Le Kremlin-Bicêtre in France. He's the Director of the Department of Respiratory and Intensive Care Medicine at the French Pulmonary Hypertension Reference Center and Severe Asthma Clinic, Hôpital Bicêtre Assistance Public Hôpital de Paris in France. Dr. Humbert? The first question for you is, what are the mechanisms of venous thromboembolic disease in COVID-19 infection? What do you think about prevention of venous thromboembolic disease in hospitalized patients with COVID-19?
Thank you very much for this very important point and very important question. So indeed, venous thromboembolic disease is quite an important complication in COVID-19 patients. And some patients indeed die of acute pulmonary embolism, and this should be prevented. So the mechanisms of venous thromboembolic disease in COVID-19 patients, they are clearly multifactorial. You have a very strong inflammation background, and this will lead to endothelial cell dysfunction, coagulation activation, and this will promote clotting. On top of that, hospitalized patients with COVID-19, they are often bedbound, they are sometimes in ICU, and clearly immobilization plays a role. So prevention of venous thromboembolic disease is very important, and it will depend on one hand on the severity of COVID pneumonia, and on the other hand on the presence of associated factors which are important for the development of thrombosis. So on one hand, severity of COVID pneumonia, we consider that the risk is much higher in patients who are on mechanical ventilation. And this is something we consider when we discuss prophylaxis of thrombosis. On the other hand, there are also some other factors which are related to the patient himself or herself, like BMI. When BMI is above 30, it's an issue. Then you have factors corresponding to important inflammation, and D-dimers above 3,000 or fibrinogen above 8 grams, it's an important factor to consider. And last but not least, you have to take into consideration the existence of risk factor for thrombosis in these people. So what we do right now in my department, and it is not a guideline, in people with COVID-19 pneumonia, which is not too severe, not in ICU, not very high flow of oxygen, we do consider enoxaparin 40 milligram per day sub-Q as a reasonable prevention. But as far as you have high BMI above 30, we do double the enoxaparin prevention with 40 milligram every 12 hours. And very importantly, when the patients present with D-dimers above 3,000 or fibrinogen above 8 grams per liter, we do consider curative anticoagulation with low molecular weight heparin, because we consider that in these very patients, the risk of thrombosis outweighs the risk of anticoagulation. So this is quite simple. This is based on experience. Other institutions will have to present data on that topic, but the take-home message is prevention of thrombosis is of prominent importance in COVID-19 hospitalized patients.
Thanks very much. That was very clear. What do you think should be the duration of anticoagulation after a patient with COVID-19 develops a pulmonary embolism?
Yeah, that's another very important point, because we have a lot of patients with venous thromboembolic disease and pulmonary embolism. What we consider is that these patients developed pulmonary embolism in the context of a transient cause. And we usually offer at least 3 months of anticoagulation with an oral direct anticoagulant in these people. All patients will be seen at 3 months with a full assessment, including a very clear analysis of persistent shortness of breath. And in case of any doubt, they will undergo a full analysis, including search for persistent obstruction of the pulmonary arteries. But right now, the decision is at least 3 months of anticoagulation and then evaluate.
Thanks. The final question is whether you have data on patients with pulmonary hypertension who develop COVID-19 infection.
Yeah, that's an important point for me because, of course, I am in charge of the pulmonary hypertension referral center in the country, and we are in close contact with the patients and with the other experts in the country. To be frank, our feeling is that these patients, they followed very well the lockdown instructions, and they stayed at home. They put some distance with their families and friends, and they followed very closely all the hygiene recommendations. Many patients are right now in contact with us. We have information from them. Most of them were not infected. And what we have launched right now, it's a survey of all the referral centers in Europe and also with the patient association. So there are 2 levels of surveys, one directed to the patients and their families, and one directed to the experts. What I can share with you is the data from my own center. We have around 15 patients with PH who developed COVID-19, which is not a very high number because we follow hundreds. And some of them very sadly died. That's very unfortunate, but patients with advanced right heart dysfunction, they have very little room for coping with such a disastrous condition, at least in some patients. But many of our patients, they had a bad time, but they survived. They went through the infection. They were hospitalized in some centers in the country, and now we are going to see them again. So to make it very brief, patients with severe pulmonary hypertension, they stayed very quiet during the peak of the epidemic. Some of them were infected, and currently we have very few bad outcomes, but we will need to do a very clear analysis of the surveys in order to be sure in the future.
Thanks very much, Dr. Rumbeck, for an excellent and clear presentation. Dr. Polverino?
Yeah. Our following speaker is from Bologna. He's a pulmonologist, he's an intensivist, he's a full professor of respiratory and critical care at the University of Bologna. And I have a lot of questions related, as you might expect, on ventilation, basically. So, Dr. Nava, the first question is quite easy. So what is the target oxygen saturation you would expect for COVID-19 patients, and particularly criteria for intubation?
Well, I think that there is no magic number, as always in medicine. I think that you should get, I would say, an oxygen saturation higher than 90, 92%. That is fine in most of these patients. And criteria for intubation, well, it depends not only on the oxygen saturation, but depends also on the general condition of the patient and their response to the treatment. Usually for a PaO2, FaO2 ratio below 200, we start anyhow one form of alternative for invasive ventilation, like high flow nasal cannula or non-invasive ventilation. And we had quite strict protocol if this technique does not work well in the first, I would say, 1 or 2 hours, then we switch to intubation, but only if they do not respond well in the first couple of hours. So having a magic number to say what is the best oxygen saturation, I would say between 90 and 92 as a minimum requirement. And before intubate a patient, you should try at least one non-invasive method for 1 or 2 hours.
And I suppose also progression over time of these patients is also important. Like rapid progression is not a good prognostic factor, right?
Absolutely, but I mean, rapid progression is only so in a small subset of patients.
Yeah.
I mean, some patients, they breathe comfortable, and then 1 minute after they need to be intubated, but you can clearly identify this subset of patients for sure.
Okay, so the following question is regarding position. Many people are asking, is there a preferred position for patients while on non-invasive ventilation or intubated patients? Is there any benefit?
Well, I was very skeptical at the beginning about proning. I mean, I do not do pronation in intubated patients because I have no equipment and stuff that can deal with pronation in my respiratory intensive care unit. So I was, as I said, skeptical, and we tried first in patient on oxygen, and we were really surprised. If you prone the patient on simple oxygen, you get, especially in a subset of patients with posterior bilateral infiltrates, you got a dramatic improvement within minutes, I would say, in PF ratio. So we start using pronation with CPAP, with high flow nasal cannula, and even in spontaneous breathing in oxygen. And if they really have this kind of CT scan with bilateral posterior infiltrates, they respond quite well. Even we tried Trendelenburg position, and anecdotally, we found even a better oxygenation rate in Trendelenburg than in prone position. This is mostly related probably to ventilation perfusion issue, but you know, these need to be assessed in a physiological study for sure, eventually after this outbreak.
So it seems to be quite related to the position of lung infiltrates, right? Posterior infiltrates.
Yes. My own experience said that.
Yeah.
Clearly, you need to verify this hypothesis in a physiological study more than clinical. Clinical sometimes does not mean anything if you're not followed by physiological data to understand what we are doing.
Yeah. Possibly VQ studies? I don't know. The following question would be about winning. Any specific suggestion? Is there a specific winning strategy you would suggest?
Well, in intubated patient, we act now as a specific winning center for intubated patient with COVID. And I found, honestly, much easier to wean off the ventilator this patient than the large majority of other patients. Like, you do not need to take into consideration much the classical weaning indices, like rapid shallow breathing or other form of index. Where, you know, once they get a decent oxygenation and they can cough well, you can easily wean them off. We have a trick. We ask the patient to do a spontaneous breathing trial, and we ask the patient first to cough and second to sing somehow, even if they have a tube in.
Italian style.
Italian style. And if they can do it, usually it works. I mean, I know that this is totally empirical, but it was really funny. We got one guy who was a tremendous supporter of a football team, and he started to sing the items of the football team, and everyone was cheering and said, "Oh, you're great." And then finally we could extubate the guy. That was funny, but it was something that it's rewarding up to a certain point. When you extubate this guy, they come back to life. So this is, I like a lot.
Wonderful, wonderful. So going back to Italy, as you are Italian, as you work in Italy, so the last question I would like to ask you is whether you have an explanation for so different case fatality rates across different countries. What's going on? Why more developed countries have higher fatality rates, in your opinion?
Yes, thank you very much for this intriguing and interesting question. So why mortality is so different? I will start with Europe, because more or less we are all considered developed countries. So I think the most important thing is denominator. How many people did you test? Because fatality rate is the ratio, as you know, between the number of deaths and the cases that you tested. I think in certain countries, definitely Italy, at least at the beginning, we started to assess only symptomatic patients. So focusing your effort only on a specific population and having the denominator formed by all these symptomatic patients, you may increase fatality rate. The second issue is about the cause of death of these patients. Do these patients die for COVID infection, or they die with COVID infection? Because this is a totally different issue. And just to make a comment, it's just like to consider old population, as we are in Italy. Most of these people, they are affected by several comorbidities, and therefore it is quite difficult to depict if they died because of COVID itself or by a comorbidity that exacerbate because of COVID. Last issue is about the different way of life, probably in certain European countries. For example, we got a quite high rate in Italy, Spain, and France. And we know that in these, would call Mediterranean countries, we have a very active social life. We like to party, to go out. So this may also explain at least part of the different fatality rate, at least in Europe. Concerning the other part of the world, I was quite surprised to see that in South America, obviously Africa is quite tricky because the assessment of a disease is not clear how was it done, and the Middle East. So I do not know if some racial differences may account, as far they account for gender, for example, or just because the virus did not hit so bad as we did in Europe because of a lot of trips that we do within Europe and between Europe and China. So I cannot really tell you, but this is going to be an issue to be studied in the next future.
Thanks to Dr. Nava for an excellent presentation. And it is my distinct pleasure to introduce our last speaker today, Dr. Charles Powell. Dr. Powell is a professor of medicine and system division chief for pulmonary critical care and sleep medicine at the Icahn School of Medicine at Mount Sinai in New York. He's also the CEO of the Mount Sinai National Jewish Health Respiratory Institute. The first question for Dr. Powell is, are there any autopsy data to support the thought that infiltrates seen in imaging studies have an embolic or thrombotic origin?
Multiple series have now been published looking at the autopsy specimens of lungs of patients who've died from COVID-related illness. And similar to the clinical presentation, the autopsy findings show that the disease is heterogeneous. A uniform finding is that almost all patients have some form of diffuse alveolar damage, DAD, and that is to be expected. There are also findings suggestive of clot or thrombus. There are many patients that show thrombus in the large vessels, consistent with a pulmonary embolism and infarct. And there's also the finding of vessels of smaller caliber showing thrombi as well. And that seems to be aligned with the concepts that endothelial dysfunction, endothelial damage, and white clot, especially in the small vessels, may be important in the pathogenesis of patients who have severe COVID. That seems to be an important and reproducible finding coming from autopsy samples. The mechanism in terms of the inflammatory pathways that cause this small vessel phenomenon are unclear. Whether or not this small vessel phenomenon, or a large vessel phenomenon for that matter, are unique to COVID has yet to be determined. The autopsy studies do not include controls from other virus-related ARDS samples, but as far as what we know right now, autopsy data do support the finding clinically that clot and thrombus are important in the pathogenesis of this disease.
The second question to Dr. Powell is, what are the risks to healthcare workers using high-flow nasal cannula compared to other types of oxygen supplementation?
This means of delivering oxygen to patients with hypoxemic respiratory failure and COVID-related lung disease. Much of the discussion focuses on the risk, particularly the risk to healthcare workers who may be exposed to virus in patients who are treated with various devices. The devices used in patients with hypoxemic respiratory failure include standard nasal cannula that deliver lower flows of oxygen up to 6 liters per minute, nasal cannula used to deliver high flow nasal cannula devices that can deliver very high FiO2s up to 100% and very high flows up to 60 liters per minute. Other interfaces used to deliver oxygen or ventilation include a mask interface that can be attached to a CPAP device or a BiPAP device. And there are masks used to deliver pure oxygen, such as a non-rebreather mask and a Venturi mask. We've been trying to stay away initially from using positive pressure ventilation delivered via mask interface due to concerns about virus leaking around or through the mask in a patient room. We've also been trying to stay away from using a Venturi mask because of the concern of virus escaping through the mask into the patient's room. So initially, we've been relying upon standard nasal cannula, high flow nasal cannula, or 100% non-rebreather mask. But I would say that we're all learning more about what the relative risks are of these devices. We've all been trying to mitigate the risk as best as we can. So for example, for our patients who are being treated with high flow nasal cannula, we try and keep the flows low, 15 to 25 liters per minute. And we also ask the patient to put a mask over their face if a healthcare worker is going to be present in the room. And we use a negative pressure room as we deploy these devices, meaning specifically the high flow nasal cannula and the BiPAP or CPAP devices if they're used. Now, we also are able to use BiPAP or CPAP via mask interface, and we are able now to attach a HEPA filter to the expiratory port of the mask, and we believe that does a relatively robust job of reducing virus exposure to healthcare workers in the room. But at this point, it's mainly conjecture, and it's a question that requires data to better inform this discussion and our debate. And we, among other centers, are gathering the data required to inform us and you about the risk to healthcare workers. So for example, we are in the midst of now doing experiments to evaluate the aerosolization that occurs using high flow nasal cannula compared to BiPAP or CPAP via a mask. For high flow nasal cannula, we use lower flows of high flow and high flows of high flow nasal cannula compared also to standard nasal cannula oxygen. and we're able to use virus-sized particles and measure the deposition in the room as we deploy oxygen through those various devices. We want to be able to compare high-flow nasal cannula to mask ventilation. We want to be able to compare both of these to standard nasal cannula so we can better understand the risk to healthcare workers. In the meantime, we do everything we can to mitigate risk by treating all patients' rooms as rooms where there's potential exposure to aerosolized virus, and all workers are protected in the fashion appropriate to that type of setting. And we hope to be able to understand the relative benefit and risks in more detail with data to inform that discussion through experiments such as the ones I described and others that are going on in other settings as well.
And the final question for Dr. Powell is, could you please give us your perspective on the new normal for the future?
So I think it's important for us to shift from where we hoped we could be several weeks ago when we were all thinking about what it would take to return to normal, to appreciating that there is not going to be an ability to return to normal for a long time. And what do I mean by a long time? I mean, as long as COVID is endemic in our communities, and as long as we cannot be protected by either a vaccine or herd immunity, we won't be in position to return to normal without either a mitigation strategy in place or a containment strategy in place. The new normal will incorporate either a containment strategy or a mitigation strategy, and the distinction between those two will be dictated by the prevalence of virus in the community or in the state or in the country as relevant. So what do I mean by that? And how do we determine that? So I said the most important characteristic to know is whether or not the virus is prevalent in the community. And the only way to know that is to do testing. Right now in the United States, the availability of testing is not adequate in most of the states in our country to be able to know with a high level of certainty what the prevalence of infection is right now. There are multiple different tests that we have to think about, and really they fall into two categories. And let me just summarize them for you right now. The two tests are PCR test for the presence of virus. The presence of virus as dictated by a positive PCR assay indicates that the patient is infectious. There are also serological tests for antibody status. In the United States, there are approximately 5 tests approved by our FDA for which the tests have been shown to be accurate, valid, and reliable. Most of the tests that are offered right now that are FDA approved are simply qualitative. They're positive or they're negative, meaning the antibody is present or it's absent. Some tests, including the test that is provided by Mount Sinai, which also has an FDA approved assay, is not only qualitative, but it's quantitative. It provides the titer. The higher the titer, then the higher the level of antibody. We use that information practically, so we identify patients with high titers who then are offered the opportunity to donate plasma for use as convalescent plasma therapy that is under investigation right now. And the titer cutoff is 1 to 320 at Mount Sinai right now. And there's research ongoing here at other sites to show what titers are required to neutralize virus in vitro. But those are the two tests, the PCR test and the antibody test. And they give us two different pieces of information. So we look at the slide here on the left. There are patients who will have a positive antibody. The clinical significance of a positive antibody is yet to be determined. Based upon prior experience, there is reason to believe that those with high antibody titers or present antibody titers may be offered some protection against new infection from this virus. That has not yet been proven. That has not yet been disproven but that is a potential clinical application. But what it is useful for is for epidemiological purposes to know what the prevalence of infection has been in the community. And recently in New York, there was a convenience population sampled in New York State, grocery shoppers. 14% were positive for antibody. And in New York City, the prevalence is 21%. So that tells us about what the prevalence of infection is. That's relevant if we start thinking about herd immunity. The concept is that we need about 50 to 60% or more in terms of prevalence within the community to have herd immunity. And even in New York City, the epicenter of coronavirus in the US, we're far short of prevalence to establish herd immunity, which is further indication of the need for a vaccine in order to adequately protect the population. All right, that's the antibody test. Then the next test is the PCR test, and some patients will be positive. They can transmit the virus, whether or not they have symptoms. And 30% of patients who are positive for coronavirus PCR are asymptomatic. That's an issue. It's important. It's a problem. They should be isolated. Furthermore, in a containment strategy, any contact of a patient who is positive should be isolated as well and tested. That's how containment is done. Somebody may be COVID negative, especially that information is important in the recent time point setting. So for example, we will do procedures on patients in a non-COVID setting if a patient is negative for a PCR assay within 48 hours of the procedure. So that's the importance and the potential relevance and application of a COVID PCR assay, acknowledging that the sensitivity of the test is limited, but we use that information to help guide us as we reopen some of our clinical practices for patients who need procedures or need to be seen in the office. And then you have patients who have no COVID test. And so we don't know what the status is in terms of their antibody, but more importantly, we don't know what their status is in terms of them being able to transmit the virus. Again, acknowledging that 30% of patients with COVID are asymptomatic. So a lot of the risk will be dictated by the prevalence of virus in the community. The probability of a patient being an asymptomatic carrier is much lower in a low prevalence community compared to a high prevalence community. So in order to move to a new normal, where there can be some resumption of activities and releasing of mitigation approaches, one has to be able to go to a containment approach that involves testing predominantly by PCR assay with, again, isolation of positive test patients, contact identification and isolation of those who are identified by the PCR assay, and then those test results can be used to determine who would be best suited for having access to various levels and various types of activities where they could be exposed to other individuals who might be at risk of getting or having the virus. The antibody assay may be used if it does provide immunity to identify individuals who would be more or less suited to be placed in the front line of a setting where they would then be potentially exposed to individuals who may have COVID and thus potentially have some clinical protection against a new infection if indeed the antibody titer was protective. So I'm not suggesting that deployment decisions be made now on the basis of antibody titer. We don't know enough now, but if it is confirmed that antibody titers do confer some degree of immunity, then it is conceivable that information may be useful in assigning deployments of employees and other staff to locations compared to individuals who might be antibody negative. And that may mitigate the transmission of virus should that occur in a community setting. So these are some of the applications of what the new normal may look like. On the right-hand side, I show you how it's being done in China right now. In China, two things need to be kept in mind. One, the prevalence of infection is very low in China right now because mitigation strategy was not released until there were no new infections in the country for 2 weeks. So that is not the approach that's being used in the United States right now. And so the United States will have a higher prevalence of infection for a while longer compared to China. But China is a low prevalence setting right now. And so containment approaches are more feasible to be deployed there. Right now, China uses an approach where people can get access to be in various social settings based upon the presence or absence of symptoms, presence or absence of fever, and whether or not they've been in contact with another person who has had the infection recently. And based upon those data, there is a system in place that individuals in China may choose to use, where there is a color code that is then presented on a smartphone device, saying that a person is green status, meaning they're free to move around the public because of no recent contacts and no recent symptoms, or yellow, meaning there might have been some risk, or red, meaning there's a significant risk. And then those color codes are used to gauge access to various settings. So these are examples of how information from testing, contacts can be used as one shifts from a mitigation social distancing approach to a containment approach in a community where the virus is still prevalent without there being a vaccine. That's the new normal.
So thank you very much. We had, I think, excellent speakers, very nice questions, and very good answers. Although we do not have the definite answer for everything, I think it was important to have a productive discussion, and we had. So we are here all together to fight this infection. And I want to thank all of the participants, the ATS and ERS and our presenters, particularly to give us their opinion. So I'm happy we are still here on the second webinar, and we hope to have more webinars in the future. So I will invite all participants to join us in the future. Thank you very much. And again, stay safe, stay healthy. Bye-bye.